Ihr seht auf dem Bildschirm, es geht schon ziemlich rund. Was ermöglicht uns das Livestreaming zusätzlich? Wir sehen hier eine Gruppe von Studenten. Man kann es nicht gut lesen. Es sind Studenten aus ähnlichen Ultraschall-Initiativen an der Uni in Berlin und in Heidelberg, die diese Summer School dazu nutzen werden, dass sie die Kurse, die Vorträge live streamen und dazu Praktika veranstalten. Man sieht ebenfalls links den Professor Tim Harris. Er wird jetzt quasi die Summer School eröffnen. Dann würde ich sagen, ich halte euch gar nicht lang auf. Was hat der Tim Harris vor? Er wird einen Fall präsentieren und hofft, dass es ein bisschen interaktiv sein wird. Das heißt, ich habe das Mikro in der Hand und er wird an die Studierenden gewisse Fragen stellen. Ich bitte darum, dass nicht ich reden muss, sondern dass die Studierenden ein bisschen was sagen. Einfach Englisch, die kurze Antwort raushauen. Wenn es falsch ist, ist es falsch. Er hat selbst gesagt, es ist ein Fall, den ein Student wahrscheinlich nicht lösen könnte. Also man hat absolut nichts zu verlieren. So würde ich mal sagen, Tim, can you hear me?
I can. I can't see my presentation. I can see a very happy chap drinking a beer.
Okay.
And I can see some people semi-recumbent just waiting to be scanned, and I can see you, but I can't see my presentation.
Yeah, we're working.
Now I can see my
Can you see
presentation.
it? Great.
I can.
But
So,
Tim, we can
ladies
hear you and we
gentlemen,
can see you.
Can you
So,
hear me?
Yes,
Yes.
I can hear you too.
Yep, there's a few thumbs, and the guy's even put his beer down, which is always a good sign. So, first of all, I'd like to thank you so much for the honour of talking to you, and apologise for not being there. Believe me, I'd much rather be there than being here. It's raining and miserable, and I'm sure it's beautiful and sunny with you, or at least in that room anyway. There's a few heads shaking, so it's probably miserable and raining there, but I've never had the pleasure of going to Austria, and I'd love to visit, and I hope I can join you in the future. So, you know, I think docs learn best with cases, and Simon and the team very kindly gave me the opportunity to talk to you and to illustrate a little bit how ultrasound has improved my practice. And be in no illusion, over the last 10 years, the most useful thing I've learned to manage patients is ultrasound. What I'd like to do now is share a case. This is a patient that I was involved with just about a month ago, and I think his care illustrates beautifully how ultrasound will make you better doctors. So when you see me sticking my hand up like that, 1, I'm waving, and 2, we're moving slides. So this was a 68-year-old man, previously very fit and well. He'd worked as a truck driver till only 2 years before I met him. He was a cigarette smoker. He occasionally used amphetamines because apparently they keep you awake and you can earn more money and drive your truck for longer. About 12 months before he came to us, he was living fully independently, although he became a little breathless over that year. His past history was high blood pressure, type 2 diabetes, a bit of drug use, and a smoker. He'd never been admitted with smoking-related disease, and until this year, he'd never had impairment of his breathing. He had schizophrenia, but he was very, very well maintained on single therapy, and he lived independently and worked independently. So he was brought to us by ambulance, and on arrival, he was sitting up in bed, breathing spontaneously, very tachypneic, hypoxic on air. He had bibasal crackles and some wheeze. Initially, we thought he had an infective exacerbation of COPD, and he received some nebulizers and antibiotics. He was hypotensive, and the fluid load was started. He was able to answer questions, but he answered slowly, so he clearly had signs of impaired cerebral function. And he was febrile. And any takers from the audience over what you think's going on? What would you be worried about, and what would your initial diagnosis be? If any of you are answering, I can't hear, so I'll answer. So he's got SIRS criteria, and he meets the definition of sepsis, and because he's confused and hypotensive, he meets the definition of severe sepsis. We'll pop up his ECG. Any of you want to have a stab at interpreting this ECG?
Don't be shy.
Is it normal or abnormal? Would you be proud to own that ECG? Well, hopefully not proud. It's very abnormal. There's diffuse Q waves, an intraventricular conduction defect, and loss of R wave progression anteriorly. So we're not sure what caused that, but his ECG is abnormal. We got some blood tests, which we're going to put up next. And these are just simple point of care tests. So they're available to the doctors in resus in just a few minutes. Anybody want to have a stab at interpreting the blood gas?
Silence.
Does silence mean it's a happy blood gas or a sad blood gas? You see, if I was there, I could walk round and give the microphone to the audience, and I find picking a member out is always a great way to get talking. I'll have to remember that for next year. So, now I can see a young woman in a grey top with glasses sitting directly in front of an ultrasound machine, and she gave the thumbs down, sort of Roman Emperor, I'm going to kill this blood gas. Would you like to tell us about the gas? I can see a moving mouth, but I can't hear a word. So that's probably a very accurate interpretation.
Yep. Good. What do you think?
I can't see it. I don't
you
wear
hear me?
glasses.
Yes.
I have to confess, we can't really see the blood gas, but there are a few circles.
Yep.
So I suppose someone has marked some concerning numbers. So that's why I gave the thumbs down.
Okay. Well, that thumbs down's very good. So let me read out the blood gas, and then you can tell us what you think. The pH is 7.35. The lactate is 5. The creatinine's 357. The bicarbonate is 16, and the base excess is minus 8.1.
Right. So lactate is 5. So already that's not good. There's something going on.
Yep.
pH is still fine-ish, 7.34.
That's good.
Oxygenation-wise, it's like...
So this was a venous gas, so it doesn't help us with the oxygenation.
Right.
What do you think about the bicarbonate being 16 and the base excess mean minus
Tim,
8?
I hear the answer.
It's acidosis, which is respiratory
So
compensated.
this is
It's an
it's an acidosis, that's correct. So this is a metabolic acidosis,
which
and the
is
creatinine
respiratory.
is 5 times normal, and the lactate's high. So this is a presumed type A lactic acidosis. So what's your definition now? With a lactate of 5 and a man with sepsis, this gives you a working diagnosis. Perhaps the gentleman in the blue top to the left of the lady that just came to the microphone, because he looks very happy and he's hiding his beer in his pocket. So would you like to come and offer us a diagnosis now? So this man's got septic shock. He's got a white cell count of 20, his platelets are 200, and his hemoglobin's 11 or 12. So he's a bit anemic. So you've got a man with septic shock. What treatment would you like to start? What's the European guidelines for the initial resuscitation of septic shock?
Well, I guess some oxygen, volume. Oh, so, damn it.
So we gave him some
Hello.
antibiotic.
Well, I'd give him some oxygen, some volume, or not some volume, a lot of volume actually, and some ceftriaxone probably. Maybe 50
That sounds very good. So we're going to give him a lot of volume, and we're going to give him some antibiotics. Typically, we'll give him 30 mils per kilogram body weight. Now we're going to move on. While that was started, we've got a portable chest x-ray. Gentleman in the red, would you like to tell us about the chest x-ray?
Well, you can see some shadows on the left side of the patient, and I'm not sure if it's as well on the right side. It's a little bit small in our window.
That's good. So you've got some shadows on the lung. They're predominantly left-sided, and I agree the left side's a bit hazy, but it's hard to see. So what's your diagnosis?
It could be pneumonia.
Yeah, so this man's got septic shock secondary to pneumonia. And the treatment would be to give him, as you said, community-acquired pneumonia. We don't use ceftriaxone, but ceftriaxone would be a very fair thing to give. We gave him some amoxil and some clarithromycin, which are the UK guidelines. And his fluids were started, and quite clearly this man needed to come into hospital. So we spoke to our medical team and asked them to come and assess him. He got normal saline, not my first choice. We usually use plasma light. He got some calcium because his potassium was high, and we started an insulin sliding scale. The medical doctors saw him and got ready to take him upstairs into one of the beds, and they gave him some more fluids. However, he became more hypotensive, and unfortunately he was removed out of resus. Simply we ran out of beds because we had 4 simultaneous trauma calls. In the next hour we got further results back. He was coagulopathic with an INR of 3.5, and his liver tests were deranged. And not surprisingly, his CRP was deranged. So this man's a little confused. He's hypotensive, he's in new renal failure with disordered liver tests. So he's got evidence of 5 organs failing. And at that point, we have enough to know. I'm sorry, was that a question?
No, sorry.
No worries. So this is the point I met him. I was just starting my shift, and I noted this man looking very unwell, breathless. Blood pressure was still in the 90s, and he'd had 4 litres of fluid. He was having a catheter put in, and he was increasingly confused. His breathing rate had increased since he came in, and his saturations had fallen to around 86%. And I went to reevaluate him. So when I reevaluated him, I got a repeat of his venous blood gas, and I formed a focused clinical assessment. He was tachypneic, he had crackles all over his chest, he was using all his accessory muscles, he had cool peripheries, low blood pressure, and tachycardic. His lactate had fallen a little, but was still abnormal. His CO2 had increased because his respiratory rate had increased, and his metabolic state and his acidosis were worse. What do you think's going on? You've got a man with pneumonia who presented in septic shock, who's had 4 litres of fluid, which is exactly average for septic shock in the first few hours, who's deteriorating. So let's take the gentleman in the black t-shirt and the looks like a pair of jeans to the right of the woman that joined us first. What would you do? Why is this man getting worse? And how would you like to treat him? You can seek advice from your team there. I'm sure they'd love to help you.
Dingen dürfen eine Heide.
So you can't actually be sure why he's getting worse. You need more information. So the first thing I did was put on the ultrasound. And what you can see here, I know you haven't done much ultrasound, so I'm not going to ask you to interpret it. Let's talk you through it. So what you can see on the screen is an ultrasound of this man's lungs. Now, wherever you look in his lungs, he had this same pattern. Those little white comet tails you can see are ultrasound B lines, and they tell you that there's blood, pus, or fluid in the alveoli. They're just like alveolar consolidation and the B lines you see on the chest X-ray. You saw his chest X-ray was mainly left-sided changes. Now, on ultrasound now, he's got these changes all over his lungs, suggesting that whatever process is in his lungs is symmetrically and equally affecting all fields. That made me worried this man had gone into pulmonary edema. So the next thing I did was I looked at his IVC. So this is an ultrasound. You're looking through the liver down into that black thing. That black thing is the IVC. And a normal IVC should be between 15 and 25 millimeters. This one was about 28 millimeters. A normal IVC is under 0 to 4 millimeters of mercury. So that's about the pressure that you breathe in and out with. So a normal ultrasound, the IVC will collapse completely as you breathe in and out. What you can see here is this IVC is fixed. It doesn't change as he breathes in and out. It doesn't collapse, and it's enlarged. And you can see that black blob coming off the top of the picture. That's his hepatic vein, and that's dilated. So this man is fluid overloaded. Say again? Nope. Sorry, I thought that was a question. So we'll move on to the next picture. So next thing we need to do is have a look at this man's heart. This is a parasternal long axis, so this is holding the ultrasound just in the fourth intercostal space to the left of the sternum. As you look at the screen, to the left is his ventricle. Immediately to the top of the screen is his right ventricle. And at the bottom of the screen is his atrium. Now, if you have a look, the right ventricle is dilated and the walls are not moving. Over the next couple of days, you're going to see a number of pictures of the heart, and you'll see that hearts usually beat vigorously. This heart is beating very poorly. So this doesn't fit with a picture of sepsis. The next picture, again, shows his heart, but this is a subcostal view. So this is holding the probe under the sternum and pointing the probe up at the left clavicle. The first thing you come to is skin, then the first blackness is his right ventricle. Then you can see at the bottom of the screen his left atrium and his left ventricle. The left ventricle is to the right and bottom of the screen. And again, you can see that it's pumping very poorly. And again, that suggests that there's no evidence of sepsis as the major cause of his circulatory embarrassment. And if we come on to the next slide, now we've added a colour box here. Colour tells you about the flow of red blood cells. And this is an apical view. So the ultrasound probe is held over the apex beat and is looking up through the left and right ventricles. So you look at the screen, to the right where the colour box is the left ventricle, and under that is the left atrium. And you can see that the colour, which tells you about the movement of cells, is moving from the atrium into the ventricle, as you'd expect. That's that big red blob. But then when the ventricle contracts and goes into systole, you can see that there's a bright blue yellow stripe. And that's fluid moving back from the ventricle across the mitral valve. So this man's got quite marked mitral regurgitation. So he's got a dilated heart, and by giving him so much fluid, we further dilated his heart and given him some mitral regurgitation. Now, he may have had this a year before, but he's had no heart murmur, and he has seen his doctor in the past, only some months ago. And you'd expect a big regurgitant jet like that to be producing an audible murmur. We've now got the same view, but with the colour box on the right side of the heart. And again, you can see the red flush as blood moves from the right atrium to the right ventricle. And then you can see the bright blue, yellow flush of regurgitation. So this man's also got evidence of tricuspid regurgitation. And in fact, we measured his pressures, and his his pulmonary tract had a systolic pressure around 50, which is very high. That's not surprising in a smoker, particularly one that's now going into pulmonary edema with pneumonia. So the ultrasound has told us that the dominant cause of this man's shock is cardiac, not distributive. The distributive shock that we expect with sepsis has a very hyperdynamic heart. This heart is unlikely to cope with the fluid load that he's been given, and he's going to need other therapy and a bit more investigation. But before I stop the ultrasound, I wanted to have a look at his kidneys, because his creatinine was 5 times normal, and previously it had been in the normal range. So what you can see now, this is the same view you get in the fast right upper quadrant. As you look at the screen, to the left is his liver, and to the right is his kidney. And what we want to know is, what's the cause of this man's renal failure? We suspect that it's sepsis and hypoperfusion, but we don't want to miss obstruction, because if he's got an obstructed renal system, he needs a nephrostomy. Now here, you can see in the middle of the kidney is a little white area. White means something that reflects ultrasound well. That's fat laid down in the middle of the kidney. And that's where you look for hydronephrosis. And I'm sure your colleagues are going to teach you about that in the next few days. So this ultrasound tells us that his kidney is not obstructed. It also tells us that his kidney is of normal size and the parenchyma is of normal thickness. That strongly suggests that the cause of his kidney failure is part of his acute septic syndrome. So you entered this ultrasound with a man who was shocked. You didn't know the cause of his shock, and you didn't know the cause of his renal failure. 10 minutes later, you know that he's in cardiac shock, and that the shock has caused his renal failure, and that he's got bad mitral regurgitation and pulmonary hypertension. Those features will help you care for him. And what we decided to do was immediately start non-invasive ventilation, insert a central line, start him on some dobutamine and noradrenaline. We chose those two because we also had measures of his cardiac output. I'm not going to go into that now. I think that would be too complex just at the introduction. He got an arterial line, we reversed his coagulopathy, and I asked for a troponin, and I spoke to my cardiac and intensive care colleagues. It was quite clear that a man in septic shock in florid pulmonary edema needs more assistance than just inotropes fluids. So we intubated him because we wanted to remove his work of breathing and also to keep him very comfortable. And we intubated him with ketamine, fentanyl and rocuronium. And we got some arterial access, and we took him to intensive care. On intensive care, we repeated the X-ray, and you can see that there's been some clearing of his infiltrates, We gave him some frusemide because it's clear after the ultrasound this man was grossly fluid overloaded. And although he'd had the correct treatment for septic shock, in this case, that fluid load was too much. He presented as septic shock, but what he really had was cardiac shock. His troponin came back at 4,500, so about 40 times our normal upper limit. We decided that he was too sick to take to the cath lab. He was slipping into multi-organ failure, so we put on some cardiac monitoring, but unfortunately he declined progressively and he died on diet 8, probably of bowel ischemia. So the reason I shared this case with you is because septic shock accounts for 2/3 of all shock we see in the emergency department. It's the commonest shock syndrome. And the treatment is quite prescriptive to give fluids and antibiotics. The problem is, without ultrasound, you can't be sure that it is septic shock. Most patients present with shock with more than one cause. For example, our patients with septic shock are also hypovolemic. So they have a hypovolemic component because they've been sweating, they've been too unwell to drink, and perhaps they've got some diarrhea. Some patients with septic shock get profound myocardial depression. And if this troponin had been 100 or 200, we may have thought that all of this cardiac depression was just due to septic shock. That wouldn't put the troponin up to 4,500. So, I wanted to tell you about a case where ultrasound completely changed my management and provided sufficient answers for me to resuscitate him and provide him with good care. Now, it didn't save this guy's life, and I do wonder if the vast amounts of fluids he had early on contributed to his death. And if we'd seen him early on and we'd done that ultrasound when he came into hospital, perhaps we would have given him the correct treatment from day one. The problem is, and I don't know how it works in Austria, but in the UK, when these people come to hospital, they're first seen by quite junior doctors. And as senior doctors, we only get involved when something's going wrong. So, you know, I really wish my junior doctors all knew ultrasound, because that could have saved this guy's life. And that's why actually it's really important you're here on this course, because the doctors that saw this, that's you next year or the year after. And if you leave this course armed with an interest in ultrasound, and you have the ability to identify what sort of shocks a patient in, you'll guarantee that you're going to give your patients the best treatment, and it's going to make you better doctors. I'm going to say again what I said at the beginning. Of all the things I've learned in medicine in the last 10 years, the single most important, the single thing that's made me a better doctor and changed the way I practice is ultrasound. So with that, I apologise again for not being able to be there teaching you. I hope very much to in the future. I'd like to thank Simon and his colleagues for putting on this conference and for helping me lose my virginity to fuse, because I've never talked over the internet before, and I think these guys have done an absolutely phenomenal job. And I wish you a really good evening, and I hope you go celebrate, Simon, because what you've done here is superb. Thank you all very much for your time.
Thank you very much, Tim.
Simon, would you like to take any questions, or do you want us to talk about any of those?
Are there any questions?
Or are we running out of time?
If there are no questions, I will ask you a question. Tim, what do you think? Could there be an increase of false positive results when a beginner is using the ultrasound with low clinical experience?
I'm sorry, I didn't quite catch that. You said about the fast scan?
Yeah. Could there be an increase of false positive results if a beginner with no clinical experience is using the ultrasound?
Yeah, you know, this is often talked about, isn't it? When somebody learns, do they give the wrong information? And my radiologists used to be very against me using ultrasound. In fact, they spent 2 years trying to stop me. All I can say, of course, anything you learn risks being wrong, whether that's taking a blood pressure, taking a pulse, listening to heart sounds. And of course it's true with ultrasound. Everybody needs to be trained, but you know, it's sound waves. You're not going to hurt your patients by getting experience. You're not going to help yourself by looking at your own heart, your own IVC, your own aorta. And the amount of material online to teach you is phenomenal. And actually the evidence out there suggests that even after between 20 and 50 scans, doctors can perform very competently, providing they're just answering really simple questions. Is the heart beating normally? Yes or no? Is the kidney obstructed? Yes or no? I think it's important not to muddle POCUS, that's point of care ultrasound, with a full study. POCUS is what we do, clinicians. We take an ultrasound probe, we go see a patient, and we answer a simple question. Is there fluid in the abdomen? Yes, no. Is there fluid around the heart? Yes, no. Is there a pneumothorax? Yes, no. We're not trying to be radiologists or sonographers and do a detailed assessment of the heart, the abdomen, or whatever. So yes, there's a risk, but you know, life ain't risk-free, and being a doctor certainly ain't risk-free. And the benefits it brings far, far outweigh those risks.
Tim, thank you very much. It was a great presentation. Bye and wishes from Austria.
Thank you. Thank you very much, guys. I hope I meet you in the future. You have a good evening. Take care.
We hope to.
Cheers.
So, Tim, you're
Yep.
off the audience
Ich darf
now.
das Wort jetzt gleich an den Simon Orlab von Sonographie weitergeben. Wir
Okay,
wissen,
thank you.
Studenten haben selten auch Freude mit der Physik, beziehungsweise mit Basics, am liebsten gleich zum Schallkopf greifen. Aber wir haben uns beschlossen, ein bisschen Basics müssen wir bringen. Und deshalb wird der Simon jetzt ganz kurz,
I've got
können
some
Sie auf eine
work
gute
to do
Show
here, but I'm gonna
gefasst
make
machen.
use on so
Er wird ein bisschen was über die Basics erzählen.
Okay.
Did that come across okay?